All right, everyone. Today, we're jumping into a diagnosis you absolutely need to have on your radar: autoimmune adrenalitis. It's a classic, but it can be super subtle, which is exactly why knowing the key features is so critical. Let's dive in.
So, let's kick things off with a classic clinical puzzle. Imagine this. Your patient comes in complaining about being tired all the time, they have this weird, intense craving for salty foods, and their family swears they look tanned, even though it's the middle of winter. What single diagnosis should be screaming at you right now?
And here's how the story usually starts. The symptoms are really vague, and they've been creeping up for months. We're talking weakness, losing weight without trying, a little bit of nausea, and that lightheaded feeling every time they stand up. It's this slow, insidious onset that makes primary adrenal insufficiency such a tough catch.
So, what in the world is going on here? To really understand the symptoms, we have to look under the hood at the pathophysiology. It all comes down to the body's own immune system, basically turning on itself and attacking a vital organ.
Okay, so the main culprit, the number one cause of primary adrenal insufficiency, what we call Addison's disease, is autoimmune adrenalitis. And the key thing to remember here is that the immune system is systematically destroying the entire adrenal cortex. I mean, all three layers. This isn't just a partial hit, it's a complete wipeout of steroid production.
And just how common are we talking? Well, it's responsible for a whopping 90% of cases. In these patients, we can actually pinpoint the attacker. Specific antibodies called 21-hydroxylase antibodies. This makes it a really specific, targeted autoimmune attack.
Think of it like a chain reaction, a really destructive one. First, bam, the immune system attacks. This leads to the complete destruction of all the cortical layers. And what does that mean? It means you lose production of all three types of adrenal steroids: glucocorticoids like cortisol, mineral corticoids like aldosterone, and androgens. Each of these deficiencies is a piece of the puzzle that builds that clinical picture we see.
All right, so we've got the why down. Now let's get practical. Let's head to the bedside. What are the telltale clues you're actually going to see in your patient and on their lab reports?
Let's break this down and connect the dots. That lack of cortisol, that's what's driving that crushing fatigue and weight loss. But the loss of aldosterone, now that's a big one. It makes the body waste salt, which leads directly to those salt cravings and the orthostatic hypertension, that dizzy feeling when they stand up. And you'll see this reflected in the classic lab findings: low sodium and high potassium. And finally, for women, losing those adrenal androgens can lead to things like reduced libido.
Now listen up. If there is one single physical exam finding you need to burn into your brain for this condition, this is it. The source material calls it a hallmark, for a very good reason. That year-round tan we talked about at the beginning? Yep, this is it.
So why does this happen? Well, it's all about a broken feedback loop. The adrenal glands aren't making cortisol, right? So the pituitary gland is just screaming at them to work harder. It does this by pumping out tons and tons of ACTH. The thing is, the precursor molecule for ACTH is also a precursor for melanocyte-stimulating hormone. So these super high ACTH levels end up stimulating the melanocytes, causing that classic darkening of the skin, especially in places like the creases of the palms and inside the cheeks.
Okay, so your clinical suspicion is through the roof. You've seen the fatigue, the salt craving, the hyperpigmentation. Now, how do you prove it? How do you nail the diagnosis for sure?
Thankfully, the workup is pretty straightforward. You're going to start with an 8 a.m. cortisol and ACTH level. If you see that classic combo, low cortisol, high ACTH, you've pretty much got your answer. But if the results are kind of borderline, you move on to the ACTH stimulation test. What you're looking for here is a double confirmation: a low cortisol that doesn't budge when you try to stimulate it, combined with that sky-high ACTH.
And if you want to be extra sure to really seal the deal and pinpoint the cause as autoimmune adrenalitis, you can send off a test for those 21-hydroxylase antibodies we talked about earlier. If that comes back positive, you know for sure what you're dealing with.
So we've got the diagnosis. Now we get to the most critical part. How do we manage these patients? And I'm not just talking about making them feel better. This is about preventing a life-threatening adrenal crisis.
For replacing the glucocorticoid, hydrocortisone is usually our go-to. Why? Because it's shorter acting, so if you dose it 2 or 3 times a day, it does a much better job of mimicking the body's natural diurnal rhythm, that normal rise and fall of cortisol. But, if you're worried about your patient actually sticking to that schedule, once-a-day prednisone is a totally solid alternative.
And please, please, please do not forget this part. This is a 2-drug plan. Replacing the cortisol is only half the battle. You have to replace the aldosterone too. That's where daily fludrocortisone comes in. It's the key to stopping that salt wasting, getting their potassium back to normal, and stabilizing their blood pressure.
Okay, everyone lean in because this is probably the single most important slide, the sick day rules. These patients have lost their ability to make extra cortisol when their body is under stress, so we have to provide it for them. Even for something small like a fever, they need to double or even triple their daily dose. For something big, like a car accident or major surgery, the stakes are way higher and they need immediate high-dose IV hydrocortisone. It is absolutely critical that every single patient understands these rules and wears a medical alert ID. This is how you prevent a fatal adrenal crisis.
And we'll wrap up with a final question, a real clinical pearl that connects all these dots. Since autoimmune thyroid problems often hang out with adrenalitis, you might see a patient with both. But before you start levothyroxine for their hypothyroidism, what's the one life-threatening condition you must rule out first? The answer, as you now know, is adrenal insufficiency. Starting that thyroid hormone can actually speed up cortisol breakdown, and if they have undiagnosed Addisons, you could push them right into a deadly adrenal crisis. It's a clinical pearl that shows exactly why mastering this topic is so essential.